Good evening, one and all. At the outset, I would like to thank ISA Ballari and Dr. Bal Bhaskar sir for giving me this opportunity. I'll be talking about the techniques of pre-oxygenation in my session. These are my session objectives. So I'll be talking about why to pre-oxygenate, what are the basic principles, techniques used, and regarding apneic oxygenation. So whenever we plan to intubate the patient, that is when the pre-oxygenation will come into the picture. And when actually we are intubating the patient, where we are not ventilating the patient, the apneic oxygenation will come into the picture. Let us consider case scenario. Elderly male, 60-year-old, he is 112 kg weight. He is a known diabetic, hypertension, and a COPD. He is edentulous and beard is present. And the second case is a pregnant lady, full term, with a gestational hypertension, full stomach, and presented for the emergency cesarean section. So, by the end of this class, one will come to know what are the different ways of pre-oxygenating these patients. So, let us begin why to pre-oxygenate the patients. So, according to the National Audit Project Port report, hypoxia remains a major cause of morbidity and mortality in anesthesia. So it accounts for up to 25% of the anesthesia related deaths. So the pre-oxygenation, what it does is it helps to increase the physiological stores of the oxygen. It prolongs the times of the desaturation during the period of apnea, and it offers the time for management of the airway during the process of intubation. Basically, there are two stages of pre-oxygenation. One, there is a circuit is involved. The other one, the patient is involved. So what they want is in the circuit, the stage one, they want the circuit to be washed out by a high flow 100% oxygenation before placing the face mask on the patient's face. When it comes to the patient, where they want us to wash out the FRC by the alveolar ventilation with 100% oxygen, where they don't want to give or make the patient to rebreathe the whatever the gases you are giving. The how much time to be given for these two techniques is determined by this. For the circuit, it is the size of the circuit and the flow rate. And for the when it comes to the patient, the FRC and the alveolar ventilation plays a vital role. Once we know the stages, so then one should decide how much the fraction of inspired oxygen to be used. So as the previous speaker already told, what are the demerits of using a high concentration of oxygen? So how to avoid them? So there are a couple of studies in which they have used a fraction of inspired oxygen 0.7 to 0.8, which are equally good when we are comparing with the fraction of inspired oxygen of a 1%. If you are planning to use lesser than that, there is always risk of a development of the hypoxemia. Coming to the breathing systems. So here what we have is the Mapleson A, Mapleson D or a Bain circuits and a circle system. So generally what we are doing is we are using say around 5 to 10 liters of oxygen for a normal tidal volume breathing technique. And for the deep breathing technique, we are using the 10 liters per minute as the flow rate. So irrespective of whatever the circuit you are using, if you can keep the flow rate say around 5 to 10 liters per minute, all the breathing systems are capable of pre-oxygenating patients within 3 minutes of time. Again, this time is directly related to the ratio of size of the circuit to the flow rate. Sometimes we are unable to pre-oxygenate the patient or there will be inadequacy. So there is a failure to the pre-oxygenate the patient. So there are mainly two reasons for this one. The first one is failure to breathe adequate fraction of inspired oxygen. Second one is we are not giving adequate time for the pre-oxygenation. Suppose we are unable to achieve the desired fraction of the inspired air, the commonest cause will be there will be a leak under the mask. For the leak under the mask to cause, there are few correctable causes, like the patient may be having a beard, edentulous patient, elderly patients with the sunken cheeks, use of wrong face mask, or a presence of a NG tube, or we are not using a proper head straps for the adequate sealing. So what are my clinical endpoints which determines, okay, my pre-oxygenation level has been reached? So this can be attained or monitored by using the end tidal carbon dioxide, end tidal oxygen, where it is advised to have a at least more than 90%, where lung is supposed to have at least more than 2 liters of oxygen, which is almost equal to 8 to 10 times of that of the oxygen consumption. The one more is the end tidal nitrogen concentration, which should be less than 5%. So how I'm supposed to monitor all these things? The simplest and the basic one is observe the movement of the reservoir bag, whether the patient is breathing, the bag is moving along with each breath. That means there is no airway obstruction. So whatever the gas is, the flow we are giving, it is reaching the lung. The same gas is coming back to the reservoir bag. So whatever the 100% oxygen is being given by the machine is being delivered at the alveolar level. The second one is based on the pulse oximeter. Again, the pulse oximeter, it is not a correct ideal method of monitoring. Since whenever there is an arterial oxygenation of say around 100%, the pulse oximeter will show it as 100%. Even though the arterial oxygen saturation increases, say around from 100 to 200, 300, 400, still the pulse oximeter will show only the 100%. It has got a ceiling, the maximum limitation. So, but suppose the baseline levels of the patient is say around 90 or 92 itself. If it is reaching means, okay, the patient's arterial oxygenation saturation is being increased. So in that sense, it is going to help us. As I told you before, the end tidal concentration of the oxygen and the nitrogen or both will help in the monitoring of the pre-oxygenation. A few words about the end tidal oxygen. So, because of the non-availability and the cost, it is not easily available with all the setup. Even in our setup, we don't have it. So, but there are some monitors which are compatible with the end tidal oxygen monitoring. So, like Massimo, Philips, and the GE monitors. Basically, they use the Capnomac Ultima gas analyzer with the fast response oxygen sensor, which is based on the paramagnetic principle. Again, these are susceptible to measurement error from the entrained air. Coming to the techniques of pre-oxygenation. These techniques are broadly divided into three categories. One is tidal volume breathing, deep breathing. Then the last one is the pre-oxygenation with an additional maneuver. So we'll try to see one by one. Coming to the first one, tidal volume breathing. This is actually proposed by the Hamilton in 1995 and still considered as a reference standard. What we do is we ask the patient to take a normal tidal volume breath with 100% oxygenation. Here we keep the flow of say around 5 liters per minute, which is sufficient to pre-oxygenate the patient. Even if you keep the flow rates little on the higher side also, it is not going to help. It is only going to cause the wastage of the whatever the gas you are giving. So what is going to happen, as the previous speaker already told you, there will be a denitrogenation happens. So there will be an increase in the alveolar oxygen concentration. So apnea time will extend up to 10 minutes after 3 minutes of the classical pre-oxygenation. Suppose if you are using this method with some amount of positive pressure, the apnea time is going to increase by another 2 minutes. The second one is the deep breathing technique. Here, what we do is we ask the patient to breathe out forcefully. The idea is breathe out all the air as much as possible. Then we ask them to take a deep breath. So, which is around 4 deep breaths in a 30-second or 8 deep breaths in a 1 minute, which can be extended to 12 or a 16 breaths per 1.5 to 2 minutes also. Here, the inspiratory flow has to be greater than the peak inspiratory flow, which is around 10 liters per minute. So, if you can give, say, around 8 breaths in a one single minute, which results in an average arterial oxygen tension of 369 plus or minus 69 millimeters of mercury, which is almost equal to the level obtained by 3 minutes of tidal volume breathing at 5 liters per minute of oxygen flow. This technique is especially useful in an emergency procedure where you don't have much time. You have to intubate at a faster time, quickly. You need to intubate the patients quickly. But this may not be helpful if the patient's lungs are having some issues where there is the lung expansion, the atelectasis, and all those things are the issues. Again, there are technical requirements are responsible for the limitation of this technique. The third technique is the with addition of the some manuals. So basically, what this methodology is helpful, especially for the critical care settings or the ICU settings, where the patient is already on the non-invasive ventilation, and we plan or decide to electively intubate and ventilate this patient. So what we do is we continue the same CPAP or a NIV ventilation with some amount of both inspiratory as well as the expiratory pressures. Continue for say around 5 to 6 minutes. Take out the mask and intubate the patient. This pressure effect especially helps whenever there is a obese patient with a basal atelectasis. But as the it comes with some drawbacks, like there is little difficulty in connecting the mask or securing the mask. There will be always some amount of gas leak under the mask. The next one is the high frequency nasal cannula oxygenation. It can be combined with the non-invasive ventilation, which helps us to decrease the severe hypoxemia during the intubation, and also useful in the pre-oxygenating the patient with the hypoxemia. Coming to the positioning the patients during pre-oxygenation. So we all know that whenever the patient comes to the OT during the intubation, they will be given a supine position. By giving the supine position, we all know that some amount of intra-abdominal pressure will be transmitted to the it pushes the diaphragm. Some amount of FRC will reduce, which leads to the drop in the oxygen reservoir in the lung. So thereby lowers the safe apnea time consequently. So what we should do is we have to give a little bit of a head up position, say around 30 to 45 degrees head up position, so that some amount of the diaphragm can be freed and the oxygenation will be better. Suppose for any reason you cannot give the head up position, you can try a reverse Trendelenburg position, especially suppose there is a spinal cord injury is there, patient is immobilized for the same. There are few techniques which enhance the pre-oxygenation. That I have pre-oxygenated the patient. Now I am planning to intubate. Now there is no ventilation. So there is no active ventilation happening to the patient. So I want to enhance whatever the pre-oxygenation technique, whatever I have used. I want to this to be prolonged so that the patient will tolerate the hypoxia in a better way. So that is called as a apneic diffusion oxygenation, APOX. This is actually described way back in 1956 by Olmada during the bronchoscopies. So what happens is during apnea, around 230 ml of oxygen is being consumed, whereas only carbon dioxide, only 20 ml is going to be delivered to the alveoli. Remaining 90% of the carbon dioxide is going to stay back in the body tissues or in the blood itself. So what is going to happen? Whenever the oxygen present in the lung get absorbed into the bloodstream or a blood and the tissues. So what is going to happen? The lung volume is likely to shrink. So it is likely to decrease. This creates a pressure gradient between the upper end airway and the alveoli, which causes the sucking effect, and whatever the air present in the upper airway will get transmitted to the alveoli. So this technique, this apnea diffusion will provide at least 10 minutes of adequate oxygenation in a healthy patient, where provided there is an unobstructed airway is present. So this technique can be used whenever we are anticipating difficult to intubate or ventilate the patient, patients with a limited oxygen reserves, or during some procedure like bronchoscopy, or brief suctioning of the tracheobronchial tubes in especially in intubated patients, or we can also use to provide the adequate time for the short glottic surgical procedure, where if you put the tube, it will prevent the surgery, it will hamper the field of vision of the surgical procedure. So in those case scenarios it can be used, but it comes with there are some limiting factors for the same. So remember, there will be a progressive raise of the carbon dioxide during the apnea. This carbon dioxide raises from 8 to 16 millimeters of mercury in the first minute of the apnea, and there will be a linear increase of the carbon dioxide, approximately 3 millimeters of mercury per minute. There are different routes of this oxygenation, oxygen insufflation. So one is the nasopharyngeal, with the help of the nasopharyngeal cannula or oropharyngeal cannula, cricothyrotomy, or some other tubes or a catheters like intratracheal or a bronchial catheters. We'll try to see a few of them one by one. The first one is the nasal prongs. So nasal prongs is the no desat, that is nasal oxygenation during efforts securing a tube. So during the pre-oxygenation, beforehand only we are connecting the patient to a nasal prongs, starting the flow of say around 5 to 15. And during the intubation time, it keeps on flowing the whatever the flow oxygen is there. It goes and collects into the nasopharynx and near the glottic area. That's how it keeps on diffusing. In nasopharyngeal catheter, we pass a tube through the nasal, this one. Then again, the same is connected to the oxygen flow. Then again, it is going to deliver the oxygen somewhere in the near in and around nasopharynx and the glottic areas. In a buccal, there is one more technique called as the buccal oxygen insufflation. It is similar to that of a no desat. So here what we do is we take a RAE tube, cut the end of this where the Murphy's eye is present, take out the connector part, connect this the cut Murphy's end part to a oxygen supply or a source. So this will be inserted on the left side of the cheek, the buccal side, where the laryngoscope is supposed to settle. So it keeps on giving oxygen during the during the intubation time. There are other modification where the laryngeal oxygenation can be done with a modification in the blade itself, like a oxyport, where the blade itself has got a port through which the oxygen can be delivered, or say around 14 French suction catheter can be taped around the laryngoscope blade itself, and which is connected to the oxygen, and that will deliver the oxygen whenever we are attempting the intubation. There are other things like nasal continuous positive airway pressure, where we are intubating orally. So the oxygen and with a little pressure can be given through the nasal route also. There is one newer technique that is called as the transnasal humidified rapid insufflation ventilatory exchange. So in this technician, insufflation of the oxygen is given at a rate of say around 70 liters per minute through a purpose-made nasal cannula to provide the oxygenation. This again provides with some amount of positive pressure, continuous positive airway pressure, approximately 7 centimeters of water. So here in this technology, there are two parts. One is the oxygenation, the other one is the carbon dioxide removal. So in the oxygenation, what happens? Whenever we are giving a high flow nasal oxygen, at a rate of say around 70 to 90 liters per minute, which enters through the nose, it loops around the soft palate, exit through the mouth. So this creates a highly turbulent primary supraglottic vortex, which causes replenishes the pharynx with the oxygen and also prevents the entrainment of the room air into that nose or a oral cavity. So we all know that the patient will be breathing or giving taking the air through the nose, nasopharynx, and the pharyngeal area. Actually, this accounts almost 50% of the airway resistance. Since the air, I mean because of the primary supraglottic vortex itself, the patient will start breathing from the glottic. So which decreases the airway resistance, because this everything will get bypassed. So that is how it decreases the airway resistance. Work of breathing will be easier. So it also generates a positive airway pressure, which in turns reduces the upper airway collapsibility and distal airway atelectasis. So this also helps in the oxygenation of the patient. Coming to the carbon dioxide removal part. So we all know that the patient will be having a cardiogenic oscillation. So oscillation, the circulation is nothing but the heartbeat. So with each heartbeat, movement of the blood through the blood vessel will causes the movement of the small airways next to them. So there will be a cardiogenic inspiration or expiration based on the compressibility or distensibility of that particular blood vessel. So if you take the each cardiac breath, that is the inspiration and the expiration, it is likely to mobilize say around 7 to 15 ml of the gas from the trachea. So the cardiogenic expiration, the carbon dioxide is removed and it is replaced by the 100% oxygen. In the cardiogenic inspiration, this moves the oxygen towards the distal airways. Suppose if you take on an average of 12 ml per beat, the movement of the gases with a heart rate of 70, it is likely to replace the 840 ml of carbon dioxide from the lungs, which is again likely to get replaced by the 100% oxygen. But remember, this is not the going to remove 100% of the oxygen or a full clearance of the carbon dioxide from the alveoli. But carbon dioxide is likely to accumulate at a slower pace. So coming to the what are the advantages of this technique? So here there will be a humidified air which prevents the drying up of the secretions, which improves the ciliary function and helps in the removal of the secretions. And it also creates a flow dependent positive airway pressure, which also opens the upper airway. There are some disadvantages like whenever we are increasing the flow rate, say around 10 liters per minute, increase in the airflow also increases the airway pressure by 0.5 to 1 centimeters of water. And as I told you, there will be a carbon dioxide, some amount of retention will be there in the lungs. The one more newer technique is the supraglottic jet oxygenation and ventilation. So here what they do is they take a specialized tube. It has got two port, one for the jet oxygenation. The other one is the carbon dioxide monitoring. So what they do is they give a jet of high oxygen, say around more than 30 liters per minute with a high frequency, and which is delivered using a driving pressure between 10 to 30 psi. This is placed just above the vocal cords and it delivers oxygen in a pulsatile manner into the trachea, which leads to the gaseous exchange. So what are the advantage of this methodology is it is ease of permission. You can just pass through the nose, just put it above the glottic opening, sufficient. It does not require a special skill or anything. And it does not have any major complication, even though the theoretical complications like barotrauma, mucosal drying, and nasal bleed have been explained. Barotrauma is never documented in any of the cases. The device can, whatever we are using, that itself will act as an airway if at all it is required. So the airway maintenance or a patency is secure maintained in this with the help of this gadget. And in also whenever in the difficult cases, if you want to intubate the patient, the same tube can be guided blindly, which will act as a definitive airway. So the main uses of this particular technique method or a technique is whenever the case scenario of a can't intubate or a can't ventilate, this comes as a rescue. There are other methodologies like endobronchial suction catheters and a tracheal tube introducer, especially the Cook's the airway exchange catheters, which can be connected to the airway source and while changing the tube itself or during the intubation time itself. So it will act as the source of oxygen insufflation. Coming to the high risk patient, how to do pre-oxygenation in a couple of examples, we'll try to understand. First one is in a aged or a elderly patients. Like the previous speaker already discussed, these patients will have a weak respiratory muscles with a reduced lung elasticity. So you have to understand they are not in a position to participate in a deep breathing exercises, deep breathing techniques. So for these kind of a elderly patients, the tidal volume breathing for a period of say around 3 minutes or a longer is beneficial. Coming to the patients with a pulmonary complication. So there are pulmonary complications which hampers the functional residual capacity, perfusion malfunction, increased utilization or a consumption, so there will be a rapid desaturation. So even if you want to disconnect the tube and do the suction for this particular patient also, they are not in a position to withstand that much long also. So these kind of a patients will definitely get benefit with the apneic oxygenation methodologies. In a pediatric patient, we all know that they have a smaller residual capacity with a higher consumption of the oxygen with respect to the adults. So the maximum of pre-oxygenation is achieved faster than the adults, as well as they also desaturate faster. So the end tidal oxygenation is achieved because of the rapid pre-oxygenation. It can be achieved within the 100 seconds. If the child is cooperative, old enough to follow the deep breathing techniques, this can be achieved within the 30 second also. But 8 and lesser age group, they will not be able to participate into the deep breathing methodologies. So these patients where they are unable to participate in any of the deep breathing or the adequacy of the tidal volume breathing is not there. So the supplemental oxygen administration has to be advocated. So which can be done with the low flow or a high flow nasal cannulas, nasopharyngeal catheters with the help of the modified laryngoscope, like I have shown in the previous slides, and the supraglottic airway devices and tracheal tubes. Coming to the pregnant patients, so these patients will have a lesser residual functional capacity, and they tend to desaturate fast, as well as pre-oxygenation is also faster in these patients. The gravidatrix is likely to push the diaphragm, so the head-up position in this patient may not be helpful. Again, the diaphragm is pushed up. The deep breathing techniques may not be helpful in these patients. So in these patients, the tidal volume techniques are better. A minute longer tidal volume technique with the increased flow rate of say around 10 liters per minute may be beneficial in these patients. Coming to the obese patients, we all know that right from the problems in the lung with respect to atelectasis, decreased FRC, high consumption. Also, there will be difficulty in holding the mask itself, and the possibilities of the difficult intubations will be there. So these patients are likely to desaturate faster than the non-obese. So these kind of a patient definitely going to benefit with the head-up positioning, pre-oxygenating in a head-up position. And manuals using a positive pressure ventilation during the pre-oxygenation, they are definitely going to be beneficial. In this chart, I try to summarize. So, what are the likely problems, and what is the likely methodologies which are going to benefit for these patients? This is basically I've done it for the best interest of the PG students. Coming to the case, two cases what I have put in the earlier beginning of the talk slides. So the first one, probably by this time you have already understood that he's a obese patient, COPD patient. So again, there is no teeth are there, and beard is present. So there is all the possibilities of there is a leak under the mask is there. Because of the obesity, atelectasis is there, they are going to get benefit with the head up position. Then tidal breathing for the 3 minutes time with the positive pressure manuals, again with the atelectasis, they are going to benefit. Obese patient, aged patient, difficult intubation and difficult ventilation situation can arise. So apneic oxygenation has to be followed. Coming to the second one, she is a pregnant patient. So gravid uterus is pushing the diaphragm. So the head up position may not help in these patient. So deep breathing technique also may not help in this patient. But yes, tidal breathing with say around flow rate of 10 plus 10 liters with the 3+ minutes may be beneficial for this patient. But suppose the case is emergency, you have to intubate on a emergency basis. You can try a deep breathing technique for this case. To summarize, routine pre-oxygenation with oxygen is standard safety measure, And most common and effective methods are the tidal volume breathing technique for 3 to 5 minutes is advocated. Or in some few cases, a deep breathing technique can also be used. And always remember, apnea oxygen technique should be considered whenever you are anticipating a difficult airway or any other special conditions. These are my references. Thank you.